let's start, please. Can we start, please? Thank you. So I told you yesterday what we'd be talking about today. We're going to start with antimicrobial stewardship, and then we're going to move on to Clostridium difficile infection. So I gave you a good introduction to what I've been talking about today in yesterday's session. So around antimicrobial stewardship, learning outcomes for this session. So first and foremost is the definition. So what is antimicrobial stewardship and some of the associated terminology. So there's not, as you will see, there's no one single definition. What's important is that you understand effectively what it's for. So you would be able to describe in some way what antimicrobial stewardship is. And there are many different definitions, some more sort of brief and overarching and some much more detailed. But basically you need to understand what antimicrobial stewardship is. With that is understanding why it exists. So what's the motivation for antimicrobial stewardship? Of course, this links very much with antimicrobial resistance. So we'll talk about some of the reasons behind it as well as what it is. In particular, and not just today, but linked with the workshop that we'll have next week, is around the role of specific individuals, be it healthcare providers or other people, that are involved in antimicrobial stewardship. And as you'll see from this session, pharmacists, and in particular the AMS pharmacists in a hospital, are absolutely key roles in an antimicrobial stewardship team. Okay? So here is where, for example, you might play a really important role in the future if you're in a hospital pharmacy. You need to be able to discuss the different strategies that are used in antimicrobial stewardship. So AMS is not a one thing fits all. I'm talking over an awful lot of people. It's not a one thing fits all. It's not that this is antimicrobial stewardship and that's what's done everywhere. It's very much sort of, if you like, organised and designed to fit particular circumstances, particular hospitals and so on. Okay, but there are some general strategies that are used in most AMS type programs and others that might be part of the program or might not. And then at the end we're going to talk about something that I brought in yesterday, which is thinking about not only what we've done in the past to try to tackle antimicrobial resistance and around antimicrobial stewardship, but what our plans for the future are. And I introduced this 20-year vision document. So I'll touch back on that, and in particular I'm going to focus on some of the actions that are in the 5-year action plan from now till 2024. And actually, if you think about it, some of you might well be in a hospital involved in one of those programs by then. Okay? So think about it that way. So what's antimicrobial stewardship in terms of a definition? If you were asked to define antimicrobial stewardship, lots of different definitions. I've put a few of them here. You might find others if you read different articles, different materials. A very sort of simple one is an overarching program to change and direct antimicrobial use at a healthcare institution. Okay. As you can see, others are a bit more detailed, so it breaks it down a little bit more. So what's inside that? Okay, well, it's about selecting the right antimicrobial, the right dose for the right duration, and so on and so forth. Okay, all of these are correct definitions. You'll need to understand in detail sort of what's behind that. But one I came across quite recently, and I've given you the reference if you wanted to go and look up the article. I quite like this as well. It's a nice simple description, but a coherent set of actions that promote using antimicrobials responsibly. Okay? That's a really nice, easy to understand description of what AMS is all about. But as I said, they can vary from place to place, but all of them will have some similarities, and depending on how big their programs are, they might have other things that don't exist, for example, even in a hospital So the problem we should be aware of from what I taught you last year about antimicrobial resistance, remember this diagram, although this is the US, it's equally applicable to us and many other countries, is that, you know, here taking 2001, and this is looking at carbapenem resistant infections. There was only, you know, they'd only been found in one state, but a few years later, they're pretty much in all states, and this is the same for many other countries. So we've got increasing incidence of resistant infections, and in this case, this particular diagram was about those very serious infections where we're talking about last resort type antibiotics, the carbapenems, and they're even resistant to those now, which leaves us with very few options to treat some of these infections. So we know this is a problem. We talked about carbapenem-resistant Enterobacteriaceae, we talked about glycopeptide-resistant enterococci, we talked about multi-drug-resistant TB, MRSA, and C. diff we're going to talk about a lot more in the next session. So of course that's a big weight, a big burden for us in terms of making treatment very difficult. And on the flip side, you say, okay, well, let's make new antibiotics, but there aren't very many new antibiotics coming along. Remember that slide from yesterday that I brought from last year? Not much new to add to that slide, okay? Very few new antibiotics coming out, and in particular, few new classes of antibiotics that have a different mechanism of action. So often you get new antibiotics that are brought in, but they have a similar mechanism of action, and they're quite similar to existing antibiotics. Okay, so this is a real problem. AMR on the increase, new antibiotic options decline. So the World Health Organization, this is a little diagram showing they have a sort of priority pathogens list of what they deem to be the most urgent infections, resistant infections that require new therapeutic options. So not everything is on here, so some things that are already a priority are not mentioned on here, like TB and some non-bacterial infections. But this is although this is from 2017, this is their current priority list. And you can see things that we've already covered. So up here, we've got CRE, DRE, GRE, MRSA, VRSA, and a number of others that I've not talked too much about. And many of these, so some of these that perhaps we have spoken less about, some of these fall into the escape pathogen list. Have I mentioned escape to you? Can't remember if I have or not. So if you come across it, just in case you wonder what it is if you see it, it's spelled, I don't think this is how you normally spell escape. It's this. And these are, so each of these stands for a particular pathogen where resistance, particularly associated with hospital nosocomial infections and antibiotic resistance, is a particular problem. Okay, and this includes things like, so the K is for Klebsiella, pneumoniae, we've got Staph aureus, and various other of the infections that we've spoken about. The A is Acinetobacter that I've not really mentioned in the past, but this is another real problem, particularly in hospital infections. So you might, if you see this word, that's what it means, the escape pathogens, particular problems for hospital-acquired infections. So, of course, one thing we can do is design new antibiotics and try to develop new antibiotics. I wanted to give you this example. This is only one example. These are drugs in research, so what might we be able to do? So we might be looking for entirely new antibiotics, but one other mechanism that we can use is to try to modify existing antibiotics. If you think about things like penicillins, many of the later, the sort of second, third, fourth generation penicillins, where we took earlier generations of penicillins and modified them, okay, to improve them in some way. So this is a nice example that illustrates the kind of thing I'm talking about. So over on the left, don't worry, I'm not expecting anyone to remember any of these structures. This is vancomycin, an antibiotic you should be quite familiar with. So in one type of vancomycin-resistant infections, so they get resistant because they use a different, so they use D-allodelac here, which means that the antibiotic can't bind and therefore can't work. So what they've done in this particular research, they've taken this vancomycin, they've changed this site that now enables it to bind to both vancomycin sensitive and vancomycin resistant infections. But they've also added 2 other modifications that have added 2 additional mechanisms of action all in one molecule. So not only does it have its usual mechanism of action, it now also, this particular moiety induces cell membrane permeability, and this one facilitates transglycosylase inhibition. So it's got 3 ways now in which it inhibits the bacteria. And it's got a hugely increased potency against those bacteria. Now this is still in sort of development research phases, but I wanted to illustrate the types of things that we can do to try to generate new and improved antibiotics. But apart from that, what else can we do? And as healthcare providers and future healthcare providers, what can you do? And that's where AMS comes in. So this I brought, showed you before. This was the last sort of 5-year strategy. These were the things particularly relevant to where healthcare providers can improve or help to improve antimicrobial resistance. So infection prevention and control, of course. Optimising prescribing, which is the focus of AMS, and improving professional education, training and public engagement. All of these will be relevant to you as pharmacists. Now this 20-year vision, again, a reminder, not expecting you to know that document inside out, but to be aware of it. So the main sort of objectives of that vision that I mentioned yesterday is reducing the need for an unintentional exposure to antimicrobials, optimising use of antimicrobials, and also, of course, investing in things like generation of new antibiotics and supply and access to those antibiotics. Now, the first 5 years of that, there's a 5-year action plan in place, and these are some of the key outcomes of this. So the aim is to halve healthcare-associated gram-negative bloodstream infections over those 5 years, so cut those by 50%. Reduce the number of specific drug-resistant infections by 10% by 2025. Reduce UK antimicrobial use in humans by 15% by 2024. And as I mentioned yesterday, it's not just about humans. So reduce antibiotic use in food-producing animals by 25% between 2016 and 2020, and then they'll set up some new objectives for following that. So that's another one. We've not really mentioned too much about antimicrobials in animal products in the food chain as well, but it actually contributes to the problem. And they want to, another one important for you, to be able to report on the percentage of prescriptions supported by a diagnostic test or a decision support tool by 2024. So really this fits very much with antimicrobial stewardship, about doing the right thing with antimicrobials, using them the best way. But just pulling those 3 as a focus. So one, just expand it out a bit. So this is about reducing antimicrobial use by 15% by 2024. This includes, in community, 25% decrease in overall antimicrobial use in the community. So presumably, predominantly this will be in GP practices. So from the baseline that they've set in 2013. And a 10% fall in the use of what are called reserve and watch antibiotics in hospitals from the baseline. Now, has anyone heard of reserve and watch antibiotics? No? You see this term? So again, the World Health Organization published what it calls the Aware Antibiotics Lists. Okay? This stands for access, watch, and restrict. Sorry, reserve. I should get it right, shouldn't I? So they have a list, and we will talk more about this next week in our workshop. So what they actually want to do, so the access, they want to promote more use of these antibiotics. So it's not just about promoting. So these are the ones that they want to be available, used. These are sort of, if you like, on the good list. So they want to promote more use of those. The watch ones are a sort of intermediate. Okay, so this is we're trying to reduce their use, so only using it where they're necessary. And the reserve is, as you'll see when we talk about it next week, again, wanting to reduce the use unless necessary. These are antibiotics and antimicrobials, for example, that have got significant toxicity, okay, and things like that. So really trying to shift to better use of what are considered safer, better, also maybe even more cost-effective antibiotics. But we'll expand on that next week. But if you see these terms, that's what they mean. So the reserve and watch antibiotics are part of this aware list from the WHO. So in the sort of coming year, in terms of the NHS, they've got certain improvement schemes. So for 1920, they've got schemes that support particular targets that I think very much reflect a lot of what we've been talking about. So there's a standard contract for acute providers. This has got a target for 2019 to 2020 of reducing antimicrobial consumption by 1% from the 2018 baseline by the end of the year. That might not seem like a huge amount, but it actually represents a quite significant amount of prescribing. There's also these things called sequins. Have you been told about sequins? Do you know what sequins are? Okay, we'll come back. I'll go over that in the next slide. So they've got these sequin indicators. So for 1920 year, they've got particular targets. One is to improve the management of lower UTIs. We've talked lots about how common lower UTIs and how are the kind of problems they can cause. So this is in older people where they can be of significant impact. So they want the management to best follow guidelines. So there's going to be a real push that treatment of those UTIs has got to follow the guidelines set. And the same goes for surgical prophylaxis for elective colorectal surgery. So again, trying to get healthcare providers to follow guidelines and best practice. Okay, so that's going to be a real focus for this coming year. So the sequins, just to introduce those to you, so it's an abbreviation for the Commissioning for Quality and Innovation. It's a framework to basically try to improve things within the NHS in either quality of services that are delivered, the types of services, and how care is provided. And antimicrobial resistance is just a sub-part of that. There are many sequins that are not related to antimicrobial resistance. So they set targets for the CCGs and the prescribers, and there are a number of these that are relevant to antimicrobial resistance. And hopefully this shows you, again, the importance in the NHS and also in the community of antimicrobial resistance. So I'm not going to go through all of these in detail, but I've given a few little notes about the types of sequins that there have been over the last few years. Sepsis I introduced to you yesterday. This is another really hot topic when it comes to these sequins. So from 2015-16, there was one set around sepsis. So they were trying to basically improve diagnosis, so recognition and diagnosis, and getting treatment, making sure that patients are treated in a good time after diagnosis. So the target set for that. And then following that, again, there was another sequin around not just identification and treatment, but also making sure that after treatment's initiated, those patients are reviewed in an appropriate amount of time, and so on. And then there's also an additional sequin looking at how many antibiotics, antimicrobials are prescribed. So that was the first one. The one just preceding the one I talked about for this year, so there was one that spanned 2 years. This was about, the overarching aim was reducing the impact of serious infections. So antimicrobial resistance and sepsis, again, big focus on sepsis. And there are different sort of, so this NEWS 2 is a sort of guideline for diagnosis and identifying patients and diagnosing sepsis. So they want people to move over to these new diagnostic tools. So the aim is to get more than 90% of patients assessed in the appropriate time with these new tools, to be treated within an hour. Again, aim over the period as more than 90% of patients, and so on. And these are actually, for the hospital, they're also linked to the money that the hospital is given. Okay? So they have financial implications for the hospital if they don't meet the targets. So, one other point before I move on from sequence that I thought were relevant. So it comes back to what I said about the 2019-2020 year. So 3 years ago, there was a point prevalence survey. If you don't know what one of those is, we'll talk about that when we do epidemiology in a week or two. 62.5% of antibiotic prescriptions for lower UTIs were deemed inappropriate. That's a huge percentage. And similarly, almost 70% of surgical prophylaxis prescriptions for digestive tract surgery were also inappropriate in some way. Hence, this current target this year of making sure that healthcare providers adhere to the guidelines for treatment of lower UTIs in older people and prophylaxis of colorectal surgery. So this is where they're coming from. These types of surveys have indicated the level of the problem. And there's another one, so this is actually not antibiotics, there's another one for prescribers about reducing inappropriate antifungals, because resistance to some of the antifungal drugs is another growing problem, and we're going to talk about fungal infections and antifungal resistance as well next week. So I wanted to point that out too. So it's not just about antibiotics. So all of this leads to antimicrobial stewardship. So we've already said what it is, but sort of what's its purpose, what's underneath this definition of antimicrobial stewardship. So there's a big focus on, of course, the patient and public health in general. Okay. It is known to reduce costs, so we'll have cost savings because you are reducing the amount of antimicrobials prescribed. Also, if you have proper prescribing, better treatment, often patients will recover quicker, they may get discharged faster from hospitals, and so on. So it can have massive cost implications. But the main driver is appropriate use of antibiotics. So the idea is to reduce overall antimicrobial use, since so much of it is inappropriate in the first place, to decrease inappropriate use, increase appropriate use, and this links very much with the AWARE list that I've already mentioned. Improve susceptibility profiles. So another sort of impact of better use of antimicrobials is that by removing the selective pressure, so remember what we talked about, how you can force selection of antibiotic-resistant infections or antimicrobial-resistant infections. If you remove that pressure by better use of antimicrobials, you actually improve what's called a susceptibility profile. So you actually can lower the incidence of antimicrobial resistance, and the types of pathogens and their resistance versus susceptibility changes accordingly. That's another aim. And of course, underneath this appropriate use, it's on selection, so which type of antimicrobial, what dose do you give it at, how do you give it, and how long do you give it for? Okay, so this is one of the key aspects of antimicrobial stewardship. So I've said it can increase the susceptibility profile, so many antibiotic-resistant infections, of course, will cause further problems for patients, be it side effects and toxicity from the antimicrobials themselves. They might recover less well. In some cases, it's linked with increases in mortality. So a range of infections are known to be associated with increased mortality rates. So you get a decrease in survival, and I've mentioned some of these escape pathogens in particular that are a particular priority. The more we have resistance, the more we have to switch to non-first line antibiotics, and inevitably then often we get more inappropriate prescribing. So it's a sort of, it's a double-edged sword. And of course, with toxicity, then we get adverse events and so on and so forth. Cost, not to be neglected. It's not the main driving force, but of course it will be a result of, and I've mentioned some of these already. So you might have people in hospital for longer. If you have a resistant infection, you're treated first line, it doesn't work, they'll have to switch. test for resistance patterns, switch you to another antimicrobial. You're likely to be, if you're in hospital for longer. Maybe you don't have such good outcomes, you have toxicity and some other side effects, and so on. Okay? So it will save costs from that side, and even just in the cost of prescribing. And I've just given an example graph from an article which is about the amount of antibiotics that were prescribed in general practice for particular patient cohorts, and it was much of it's deemed inappropriate. So in community as well, it's not just hospitals, but in community there's still a lot of inappropriate prescribing. And if you remember last year in PM2A2, I showed you a quite recent review of that, and I gave you some of the data of the percentage of antimicrobial prescriptions in general practice that are likely to be inappropriate. Patient safety. Again, we've talked about some of these. Inappropriate prescribing and inappropriate use as well can lead to things like medication errors, drug-drug interactions. So when you get away from first line, often you then have to deal with more increasing drug interactions as well. So there are a lot of considerations around safety of the patients that AMS should also help to improve. So toolkits for AMS. AMS really kicked off all with a focus around hospitals. So it's very much a hospital-led idea, but it's now been very much expanded out into primary care, out into the community as well. So there are two main toolkits in the UK. So there is Target, here's a little logo for primary care, and there's the Start Smart Then Focus for secondary care. Who's heard of Start Smart Then Focus? Probably come across that, quite a few of you. Anyone heard of Target? Okay, so that's effectively the community version of. So there is a toolkit for healthcare providers within those sectors for helping to obey and to generate and develop AMS in their settings. So in a hospital, in an antimicrobial stewardship team, there can be a variety of different members depending on the size of the hospital, the size of the team, etc., type of healthcare setting, but there will be some core members always in that team. First and foremost is the clinical pharmacist. Okay, is one of the leading core members in any antimicrobial stewardship team. Okay, and that might be you in the future. There will be a clinical microbiologist and or an infectious disease doctor, physician. They're the core members of the team. Then there may be a number of other members within that team, so quite often an epidemiologist in the hospital. As I said, if you're not sure what epidemiology is, we're going to talk about that. We've got a session in a week or two. There might be non-clinical management team members, certainly infection control nurses are likely to be in that team. There can even be people you might not expect, so IT specialists, but quite a lot of this will be on looking at data and information, patient records, some of the electronic tools used for prescribing and so on. Okay? But these are your core members of the team. They collaborate with a range of other people within the hospital, in the healthcare setting. I'm not going to go through all of these, but it's quite a wide arching role, but within the team itself, those are the core members, but they will likely be speaking with people like above, so the trust and governance of the hospital, maybe on strategies and things like that. So what are the actual strategies in an antimicrobial stewardship programme? Lots of different things it could be. This is not even an exhaustive list of things that might be part of a programme within a healthcare setting. But the top two, usually one of those is the main basis for an antimicrobial stewardship programme. And I'm going to go and explain what some of these are in more detail. So formulary restriction. Formulary, you should all be familiar with what formulary is, and we'll talk about what we mean when we say formulary restriction. Or review, audit and feedback. So it's usually one of those methods as the sort of core. And then there could be a range of other things. So there will be education and training. There are of course guidelines, things like antibiotic cycling. We're going to discuss what that is later. So a range of other things, but these are the key ones. So formulary restriction Again, there isn't a type of formulary restriction. It's not one formulary that will be used everywhere. They will have a specific formulary set for the hospital. And this is where dispensing is restricted. And the restriction can be on a number of different levels. So it might be that prescribing or dispensing of certain drugs are restricted by indication. So you're only allowed to prescribe for a specific indication, otherwise it's actually restricted in the formulary. A number of criteria that might have to be met before they're dispensed. Only certain prescribers may be able to prescribe certain agents. It might be restricted to a particular service or ward or patient groups. And within this, they may require what's called prior authorization or prior approval. And that could be, for example, from the antimicrobial stewardship team. It might require input from the microbiologist and so on. Okay. But restriction is at the level of what's actually allowed to be prescribed and dispensed. And it could be restricted in these ways. So, in fact, the hospital formulary, they may only have specific options, and others may not be available. So there's lots of levels of restriction. The antimicrobial committee will typically be the ones that decide on how this formulary is set up. And certain personnel that ensure that people adhere to that. And again, one of those will be the relevant pharmacist. Pros and cons. So it's got some advantages. So it gives the healthcare institution a lot of control over what's prescribed for what and where and so on. So it's quite direct control. It can be very cost effective, so they might set the formulary to only allow a cheaper option, for example, of a particular antimicrobial. There's some opportunities for education there, but you can have the pharmacists actually have to be asked for approval, or somebody else, as I mentioned on the previous slide. So there can be intervention by the pharmacist. But there's a sort of automatic awareness of what can and can't be prescribed because of the formulary restrictions. So it makes people aware of what they can and its limitations. But actually that's a bit of a con as well in this case. So it's a disadvantage because for prescribers it can give them a sense that they don't have autonomy, they can't prescribe what they would like to prescribe. They've been actually more restricted and they're not allowed to prescribe what they think is the best choice. Where prior approval is needed, so where somebody has to seek approval, for example, from the microbiologist or the pharmacist before the drug is allowed to be dispensed, you have to have somebody on call for that. Okay, so there has to be somebody around in order to approve that agent. So it can be very time consuming from that sense. And of course you need to enforce it. So sometimes there are loopholes and ways around formulary restriction. So it has to be enforced. An alternative way of doing things is what's called review or audit and feedback. So here the prescriber can prescribe and initiate treatment, but there will be review of what's been prescribed for their appropriateness. So there'll be a number of cases chosen and targeted and reviewed by the relevant pharmacist. So in this case, the antimicrobial steward, the pharmacist, you as the pharmacist, they will assess the case and contact whoever was the prescriber in that scenario with feedback. Okay? And that could be recommending an alternative therapy. So they've reviewed it, and as the specialist pharmacist and the antimicrobial stewardship team, they've deemed the treatment not appropriate, there is a better option, and they will provide feedback to the prescriber. So there are guidelines around this. And here, of course, the pharmacist is reviewing, on a sort of case-by-case basis. It's usually targeted to specific cases. And again, like formulary restriction and prior approval, it's got some pros and cons. So here, prescriber has no loss of autonomy. They can initiate treatment with the agent that they want to. It will still obviously fit within the formulary of the hospital, but it's not restricted in the same way. There's a lot of opportunity here for education, especially through the pharmacist and providing feedback for the prescriber. So an opportunity to explain perhaps why something is not the most appropriate choice. There is some evidence that this has shown to decrease unnecessary or inappropriate prescribing, which is, I suppose, not a surprise. It doesn't cause any delay in initiation of treatment. Okay, so they can just get started straight away, and it's quite a flexible way. But it's got disadvantages. So again, it requires compliance. It's all voluntary. There's no immediate prescription restriction to prevent prescribers giving what they want to. So it requires you sort of to be involved and complying with what's suggested. Huge workload increase for the pharmacist as well. Okay, having to review cases on a case-by-case and patient-by-patient basis. And it's considered more reactive versus proactive. So instead of just making sure you start on the best thing from the very beginning, instead you're looking back and then swapping if it's not the best thing. So it's more of a reactive type of scenario. And giving more liability. So those are the two sort of generally sort of basis of any antimicrobial stewardship programme. Prior approval we mentioned already, so this can sort of work in combination with things like formulary restriction. So the prescriber has to contact the microbiologist and make sure that they can approve what they want, often done just over the phone. But of course, if this is out of hours and they can't get access to a microbiologist, this can cause some problems as well. Again, it's a sort of loss, it removes the loss of autonomy, so prescribers can say, actually, I really want to prescribe this, can you give me permission? And there'll be reasons behind that. So it takes that away. But it's got a number of disadvantages. I've already said about sort of out-of-hours problems. There are often ways around this, so prescribers might find ways of circumventing the prior approval to get what they want. There's a lot less opportunity here for education of prescribers in choosing the best agents. There can be communication errors. Okay, so by phone, things might be misinterpreted, so there's an increased opportunity for error. In cases where you might get approval, you actually might still not be using the appropriate antibiotics. There's been no particular studies showing the long-term benefits, and also you can sometimes have a shift of which antibiotics are used. So it's got pros and cons again. So those are all the sort of key core features. And associated with that will be a lot of other sort of ancillary parts of the programme. Education and guidelines is not surprising at all. Of course, these exist in all healthcare institutions. So there'll be a number of specific guidelines around antimicrobial use. You've seen already things like the sequins that I've talked about, and other sort of improvement schemes within the NHS. There'll be a range of guidance, schemes, and education opportunities. In terms of education, so what are we talking about here? So trying to educate healthcare providers. Again, here pharmacists play a lead role. So very often you might have the specialist infectious disease pharmacist providing education, and it could be at any level. It could be a range of, it could be students, trainees, it could be senior healthcare providers. So that, again, the antimicrobial committee around the antimicrobial stewardship team often are creating those guidelines. Advantages of sort of, education and guidelines. So guidelines are exactly that. They're not rules, they're guidelines. So it can be great. You might change somebody's behaviour. It's voluntary, so people don't feel forced into doing something that they don't want to. That, again, they've got autonomous prescribing ability. But with education, anything that's, for example, a written document, you just assume someone's read it, that they've learned and taken it on. It's very much an assumption that it's going to change their behaviour, and it might not. And generally, unless it's in coordination with some of the other strategies, that it's largely ineffective. So you can have guidelines, but if they're not adhered to, then they're largely ineffective. Another important strategy is streamlining, or what's called de-escalation. So this is where you change. So if you have to start treatment immediately for a serious infection, you will just give the empiric treatment that's most likely to be covering the organisms involved. This is about switching then, once you know more, you've got more information about switching if necessary, to a more appropriate agent. So it might be that you've got microbiology lab results, so now you know which organism it is, you know what it's sensitive to, and you can review, look at what the patient is currently receiving, and for example, if they're being given a broad spectrum agent and there's something much more narrow spectrum that is appropriate for their infection, you can switch. So lots of things here, but typically we'll rely on things like laboratory results. And again, key person here will be the pharmacist and the clinical microbiologist. Lots of advantages. Reducing use of broad spectrum antibiotics, we know why that's a good thing. Tailoring treatment to the patient, or increasingly we're trying to look at patient-centred healthcare. So you're tailoring your treatment to the specific patient because you're targeting the organism. So you actually should have a much better outcome, being specifically looking at that particular organism. We reduce the pressure for antimicrobial resistance, particularly if you're shifting from broad spectrum to narrow spectrum. We reduce inappropriate use of antimicrobials. They might be stopped. Very often we'll save money, maybe not always, but often we'll save money. And very often allows us to use safer antimicrobials. So if you have to go in with an empiric therapy, you have to just cover all likely pathogens. Once you've identified what it is, you can target it more specifically and choose perhaps a safer agent. Disadvantages, again, so of course there's workload involved here, so you've got sample testing, review, going back, changing therapy and so on. Sample processing time, so often it might take several days until you've got the test results back. So they may be having a less appropriate treatment for that time. You need the right tests. And actually you might have resistance from prescribers to change what they've already prescribed. Okay. So because people are human. Okay. A bit linked with a sort of similar line to that is an IV to oral switch. So often if patients come in and they're very unwell, if they've been admitted to hospital, they'll have some sort of parenteral therapy. So continuing them on parenteral therapy might not be appropriate. If they're well enough, for example, to take oral medication and there's a good option, then it should be switched to. And we'll cover some of this a bit more detail in our workshop next week. Lots of agents have got really good oral bioavailability. Okay? So it might be a straight switch from the exact same agent from IV to oral, or it might be a similar switch, something with a similar spectrum of activity, but that's got very good oral bioavailability. And I've given some examples of some key antibiotics that have actually got good high levels of oral bioavailability. Again, you as pharmacists will be those with that type of knowledge, that key specialist knowledge of which agents have got good oral bioavailability, which are maybe intermediate, and which are poor, and you might have to find an alternative. Or in fact, you may have to continue with IV. Advantages obvious in terms of entry site infections, so always an opportunity. We were talking about yesterday with skin infections. If you break the skin, it's an opportunity for infection to get in. Lots of cost savings here. Of course, much easier to give patients oral medicines than IV medicines. They might get out earlier. So if your patient's actually, all of the things being considered, well enough to go, obviously they can't leave them there on an IV, but they can leave if they've got oral medication. Okay, so think about something I mentioned yesterday, like mild community-acquired pneumonia. As long as they're well enough to be sent home, they might be sent home with oral amoxicillin. Disadvantages, of course, if you send patients home with oral medicine, you've got adherence or compliance issues to consider. Okay? But it's got lots of advantages. Now, antibiotic cycling, I don't know if anyone's heard of antibiotic cycling. So this can be used, it's not always part of a stewardship programme, but this is where you have a sort of scheduled annual rotation of the use of specific antimicrobial agents for a particular indication. So, certain months of the year you might use one, and then other months of the year you use another. So the theory is that by not having a constant use of one antimicrobial, you reduce the constant selective pressure on that organism. So that's the sort of theory behind it, with a view to slowing the emergence of resistance. Again, the antibiotic committee, the antimicrobial committee, would create their sort of protocol for cycling that particular indication. And again, key people, the doctor and the pharmacist here. Now, there's actually, in terms of evidence, it's a bit good studies, good well-designed studies to prove effectiveness are fairly lacking. And that's actually one thing that's true for lots of antimicrobial stewardship programs. They might have been designed very well, but it's sometimes not recorded, or it's the study to decide how well they've been, how effective they've been, are not very good. So it's very difficult to ascertain how or if they've been effective. So they might be, but it's not always difficult. It's not always easy to tell. So with antibiotic cycling, it's possible it will reduce selective pressure. And here's a sort of example where you might. And here's the reference if you wanted to look it up, where you might cycle 2 drugs in 3 monthly periods around the year. But apart from the fact there's not a lot of good evidence, it doesn't mean there's no evidence, but the evidence that's available in the literature is often quite poor. It can be difficult to get adherence to some of these programs. It's fairly theoretical. You might get people not complying, but also another thing is if you've got patients that are allergic to one of those agents and you have to use something else, you can't stick to this cycling, or there might be more toxicity and so on with particular agents, one over another. But I thought it's sort of interesting to introduce from the idea of the theory behind it, of trying to prevent a constant selective pressure. And then there's a whole bunch of other strategies. I'm not going to spend too long on them. But there are clinical pathways, you'll be very familiar with some of these. Things like antimicrobial order forms that help to guide, especially electronic and computer-assisted prescribing, help to guide correct choice of antimicrobials and also help with review. Combination therapy, I'm going to come on to very briefly in a second, but a little bit of detail on some of these. You can read them, I'm not going to go into great detail with them. But things like the order forms, why can they be useful? So there might be automatic stop orders for certain things that have been prescribed that will help to reduce inappropriate prescribing. They can be particularly useful for prophylaxis, so they might stop people prescribing prophylactic antibiotics that are inappropriate, or they might reduce how long they're prescribed for. And they can be done on a sort of organisation-wide basis. So if everyone's using these types of systems on an electronic system or not, but increasingly these are all done via electronic systems. So this can be very useful in helping to guide people to give the appropriate agents. Now, combination therapy you could look at 2 ways. So the idea would be, of course, as it suggests, combining agents, so you widen the spectrum of activity. So actually the idea is that you sort of kill off the infection in a better way. But you might have sort of redundant spectrums of activity, and there's really not a lot of data to support that combined therapies where you try to target with multiple mechanisms of action, etc., broader spectrum of activity. There's not a lot of evidence to suggest that this is necessarily the better course of action. But I wanted to mention it's something to think about. So, where is sort of AMS, antimicrobial stewardship, going? How is it proved so far? One thing that is required are good, sound studies. So it's one thing to put a program into place, but how do you know if it's worked? So what would be really good in the future, and people are doing more and more, is to have sort of well-designed studies to assess impact. And that includes sort of mathematical models. Lots of work on antibiotic use and resistance is required more. Need to assess the long-term impacts of those core features of antimicrobial programs like formulary restriction. How does it affect? It might, for example, if you might change antibiotic use, but does it affect actually the levels of resistance? Remember, one of those targets of antimicrobial stewardship is trying to increase the susceptibility profiles. So is that working? Do you see a shift in the resistance or susceptibility profiles of the pathogens? Antimicrobial cycling I've mentioned already. You might want to look at how effective it is in particular patient groups. So certain things may be more effective in particular scenarios. And of course, we don't have much evidence on combining agents, how effective actually that might be for particular infections. How effective are they? There's evidence in both ways, both directions. So there's some evidence, for example, certainly evidence that it can change prescribing practices. So they might sort of adhere better to guidelines and policies through antimicrobial stewardship programs. There's been evidence of showing that antibiotics are given for reduced amounts of time, patients staying in hospital for shorter periods, and some evidence in some studies that they're actually improving the susceptibility profiles of bacteria. Now I've put you the link, you can just click on it if you want to go and look. There's actually a couple of years ago a Cochrane review on this, which is really interesting about hospital prescribing and the different types of interventions. And here's another, just an example to show you the types of data that are available. So this was a randomized control trial in the US, looking at the effects of antimicrobial stewardship program and patient outcomes versus no antimicrobial stewardship program. So ASP is with the program. The lighter grey bars are usual practice without the program. So percentage of patients here, amount of antimicrobial prescribing that's appropriate went up to 90% with the program, from just over 30 without. Effective cures for those patients, again, was up to just over 90 with their stewardship program. Started out just over 50 without it. Failure in treatment, so whether antimicrobial was ineffective, decreased from just over 30 to around 5 or 6 with their program, and the level of resistance decreased. So that's an example in this particular study. So it can be effective. But there have been reviews recently about sort of systematic reviews across a range of different studies. And again, I've highlighted one here if you want to go and have a look. So some have shown effectiveness, some have shown less effectiveness. But we need more of these types of studies to try to look at how best to target, which things work best and where. So I mentioned the two toolkits. So the Start Smart and Focus that some of you are familiar with already is the hospital one. And for anyone who can't remember what that is, so the start bit of Start Smart and Focus is don't start if there's no evidence of infection. Sounds a very obvious one. But we're not treating things like colonisation, we're treating infection. And you'll say, what's the difference? Actually, when we talk about Clostridium difficile, hopefully there'll be a good example of that. Use guidelines for prompt effective treatment, so follow the guidelines effectively. Documentation is a big part of Start Smart Then Focus. Make sure that everything's clearly documented so that others can follow it. If possible, get cultures before you prescribe. Of course, that's not always possible. With a serious infection, you might have to initiate empiric therapy, but if possible, get cultures first. You can tailor the therapy. Single doses for prophylaxis where that's important. So we talked about prophylaxis in the last few slides. So that's the sort of start part. And then it's focus. So what do we mean by focus? Every patient should be reviewed within 48 hours. So whatever therapy they've been initiated on, should go back and review that patient with an action plan. Okay? And the action at that point could be a range of different things. Okay? So lots of different options here. It might be stopping. Okay? It might be a switch, and we talked about things like de-escalation, and we talked about IV to oral switch. You might have to change, so actually you might find that you're giving the wrong thing or too broad a spectrum, and you can alter. You might be absolutely, as you're, might be correct. You might be doing the right thing, and then everything continues. Or you've got the OPAT. So there's a range of different things that might happen. I would imagine stopping is not is probably the less common, but certainly switching, changing and continuing. So if you're following guidelines, in fact, often it might be that nothing changes at that stage. Okay? And again, clear documentation. So you've reviewed any changes or continuing of therapy, microbiology results, and so on. Clear documentation. And this is the sort of little chart, little algorithm of Start Smart Then Focus, which is just slightly more detail of what I've just told you. And again, I've given you the link. You can go to the full documentation if you've not seen it before. This is a sort of summary of top tips. Again, you can read this for yourself. But these are the main things around Start Smart Then Focus. Sort of do's and don'ts and key aspects. And I wanted to bring your attention to these if you've not seen them. Anyone seen this, Antibiotic Guardians? I think it was in one of your week 6 options, activities. So people can sign up to become an antibiotic guardian. You can sign up as a member of the public, and there are certain things you're sort of saying that you sign up to, or you can sign up as a healthcare provider. And on the other side is European Antibiotic Awareness Day. So this falls on the 18th of November every year. And you can find out what that's all about from their website as well. So coming back to our learning outcomes, you should know or be able to define antimicrobial stewardship. What is it? What are some of the terms that go with it? We've talked about certain ones of those. Why? Why do we have antimicrobial stewardship? Why is it important? Who is involved? And who are the key players? Okay, and we know, of course, the clinical pharmacist, the infectious disease pharmacist, is one of the key people in that team. Should be able to discuss some of the strategies, particularly those core strategies that are involved in antimicrobial stewardship programs, what are their advantages and disadvantages, and then sort of where have we been in terms of AMS and where are we going in the future. And this includes not just that big vision document, but some of the UK's key aims over the next 5 years, and those sort of NHS strategies like the sequence. There's no multiple choice yet because that's next week's workshop. So there'll be a few starter questions to get you warmed up in that session. Here again, lots of links just to save you going to look for things. I've starred things that I think are particularly useful. So this Target antibiotic toolkit for GPs that seems very few of you have heard about. You can just go and have a quick read about that. I think that's quite useful, especially because now there's increasingly pharmacists in GP surgeries. So some of you actually might find yourself in a GP surgery as a pharmacist. The past antimicrobial strategy and this 20-year vision, do recommend a quick look. And there's actually a review commissioned by the UK government on antimicrobial resistance that I also think is quite useful. Just to have a quick look to give you a bit more of an overview. And again, there's a link. So there's a really nice article, I think it's a couple of years ago now, specifically about the role of the pharmacist in antimicrobial stewardship. And if you want to get a chance to have a look at this ahead of our workshop next week, which is very much going to focus on this area, I think that's really useful too. That's it for our first part. I'll let you take a break, and if we start just before 10 past, and we'll do Clostridium difficile.